your current understanding of recurrent urinary tract infections, which you think you know, and hopefully kind of turn some of that around. Because I think a lot of us still practice management of these infections a lot like we did for some of us 15 years ago, for some of us less than that. And there's actually quite a lot, I think, that's changed in my practice, a lot of migration in my practice. And to be honest with you, I think a lot of the things that we were doing 10 and 15 years ago were probably, I don't know if I would quite say we were doing harm, but we certainly weren't doing a whole lot of good. If you think back, to Campbell's chapter on recurrent urinary tract infections 15 years ago, it essentially said, what can you do about recurrent urinary tract infections? You look for any underlying abnormalities and then just write a bunch of prescriptions for antibiotics. I mean, that was the management of urinary tract infections, and I think we've come a long way beyond that since then. I have no conflicts regarding this discussion. And so first thing I think we need to do is review the identification and management of lower urinary tract infections. What are recurrent urinary tract infections? How do we identify them? How do we appropriately evaluate them? And really with a focus here on appropriate antibiotic stewardship. And I think that's clearly been a buzzword over the last few years, and I think it's going to be the focus of our talk today. We want to talk about both the evaluation of and then the preventative strategies for recurrent lower urinary tract infections. And then I think a key part of this, though, in understanding what a urinary tract infection is to understand the concept of asymptomatic bacteriuria and how we should address that. So, the obligatory introduction slide. Why is this important that we're talking about it? Well, urinary tract infections account for 7 million outpatient visits annually in the U.S. A third of women report an infection by age 24. And women who have a urinary tract infection, 80% of those will report a recurrent infection and not a recurrent UTI by our definition, but another symptomatic infection at some point over the 18 months. So, obligatory slide done. Urinary tract infections are prevalent, they're important in our practice, and so we should pay attention for the next 55 minutes. So definitions, I think, are always very important. So first of all, we need to talk about what is a recurrent urinary tract infection, right? I have 10 or 15 people a week sometimes referred to us for recurrent urinary tract infections. All of these things have definitions, and we all understand definitions are important, so we're all speaking the same language. So recurrent urinary tract infection is defined as greater than 3 infections over 1 year or 2 infections over 6 months, and that's part of my standard intake questions that I ask patients when they come in referred for recurrent urinary tract infections. And oftentimes I think these two are confused, and I think it's very important we distinguish them, right, because we have different management strategies for complicated urinary tract infections versus simple recurrent. A recurrent urinary tract infection is not a complicated urinary tract infection, right? A complicated urinary tract infection is associated with some structural or functional abnormality of the urinary. Some recurrent urinary tract infections are complicated because there is that structural or functional abnormality, but it might be 10 or 20%. So the reason I point this out is because a lot of the patients who refer to me for recurrent urinary tract infections, they've been treated a lot as if they had complicated. So what's the difference between treating a simple urinary tract infection and an uncomplicated urinary tract infection? It's typically the prolongation of treatment duration, right? So when I see patients who have had 2 or 3 or 4 different urinary tract infections over the last year, what do you think has happened to that duration of treatment? It's gotten longer and longer and longer, right? So someone comes in, they have a simple lower urinary tract infection, and they just completed a 14-day course of ciprofloxacin. And to me, that says that we're misunderstanding. We read, hey, complicated urinary tract infections need longer courses of antibiotics. But as we'll talk about in just a moment, that's probably the opposite of what you want to do in a recurrent urinary tract infection. So I know it seems like a very simple, I kind of understand that, but understand that our treatment oftentimes doesn't reflect that, okay? And I find even myself sometimes have that reflex of, somebody comes back with another urinary tract infection or a bad urinary tract infection, all of a sudden I just want to put them on a longer course of antibiotics to make sure I get rid of it. But that's not right. There's no science behind that. In fact, the science says the opposite. Here's another, I think, very important distinction that I think you guys probably know if you've read Campbell's, and you all have, and that's this distinction between bacterial persistence and bacterial reinfection. Right? So recurrent urinary tract infections typically happen either because the bacteria aren't going away, bacterial persistence, or because we're getting a new infection. And that's a very important distinction because bacterial persistence tends to imply some structural or functional abnormality. Typically a bladder diverticulum or urethral diverticulum or bladder stone or incomplete emptying or something along those lines. So when you detect a patient with bacterial persistence, which again I think maybe makes up about 10 or 20% of these recurrent urinary tract infections, you want to be much more aggressive at looking for these anatomic abnormalities that lead to the persistence versus the reinfection. Reinfection is not really, it may be associated with some risk factors, sometimes induced by us, but it's not typically associated with an anatomic abnormality. We do have ways of getting rid of infections. One of the things I always point out, we'll talk about this later on, is, for hundreds of thousands of years, human beings had urinary tract infections. We didn't have antibiotics. How did we ever survive as a species? Well, besides having an immune system, we have certain host defenses. And I mention these because at least 3 out of 4 of these are ways that we currently utilize as strategies to prevent recurrent urinary tract infections. So the glycosaminoglycan layer, which is relatively impermeable and acts as a defense against bacterial adherence. Horsefall proteins, which there's been some work in trying to increase this, but nothing that I incorporate in my practice today. Urinary and vaginal pH is critically important. We'll talk about that in just a little bit. And then probably the most important host defense, because we're the ones who are typically negating this host defense, is commensal flora. So how do we diagnose a urinary tract infection? Well, for most of us, that diagnosis begins and sometimes ends with a urinalysis. So, dipstick urinalysis in the office or sent off to the lab. And that's predominantly 2 quantities here, the nitrite. And it's really important to understand, I think, here the sensitivity and specificity of these and what they tell you and what they don't tell you. I think that's the story here, is the tests you're getting to diagnose urinary tract infections, can you learn from them, but what are the pitfalls? And so sensitivity, not particularly good. It's 60%. So it's not a very sensitive test simply because not all pathogens reduce nitrate to nitrite. The specificity is 95%, but the specificity of what? The specificity of bacteriuria, right? So understand, when we always talk about, nitrate's a very sensitive test. Well, it's sensitive for bacteriuria. It's not sensitive for infection. So when you see a nitrite-positive urine, understand what that's telling you is that that patient has bacteria in her urine or his urine, and that's really all it's telling you. Leukocyte esterase has a very good negative predictive value of 90%. But again, has a low specificity, kind of the opposite of nitrite, because it only is a marker of inflammation, not of infection. I think urine cultures are very useful, but we have a couple of really big pitfalls that we run into with urine cultures, and I see this every single week, both in patients who are referred to me, as well as in the patients that we take care of. My nursing staff is, my notorious for this, is they sort of have an understanding of a urine culture as it's sort of a yes or no, positive or negative. If the urine culture is positive, that patient has an infection. If the urine culture is negative, that patient doesn't have an infection. And I've heard stories of patients, standing in the office, writhing in pain, burns every time I urinate, and I'll hear a nurse say, "But your urine culture was negative. You can't have a urinary tract infection." This patient and her bladder begs to differ, right? So understand the limitations of urine culture as you use it. First of all, and here's the first pitfall of urine culture. It can exclude symptomatic patients with low colony counts. And we're going to discuss that a little bit later on. But what you understand as a significant colony count has a lot less validity than you understand it to. That 100,000 CFUs, we'll talk about in just a moment where that comes from, and I think it'll surprise you. It surprised me when I was preparing this lecture. The second is that urine cultures can include asymptomatic patients with bacteriuria. And I think this is probably even more common, right? So a patient goes to see her doctor, urinalysis looks a little funny, maybe it's nitrite positive. She gets a urine culture and she gets put on an antibiotic, all without ever mentioning any symptoms. And so I think this is the greater pitfall of urine cultures, is that it causes overtreatment. So urine cultures lead to undertreatment, and I think predominantly they also lead to overtreatment. Lastly, C-reactive protein, I mentioned it more for an academic reason, maybe elevated in acute but not chronic infections. Again, this is not something that plays a role in my current practice. So when do we need to do urine cultures? When are they important? When are they useful? So I think, first of all, we need to understand that the diagnosis of urinary tract infections is predicated on symptoms. And I tell my patients this every single day. Unless you are, are not neurologically intact, if you don't have an infection, if you don't have symptoms, you don't have an infection. That's in the story. A diagnosis of urinary tract infections for the vast majority of people are predicated on symptoms. I think urine cultures, as we talked about, they inform us as to bacteriuria. So when you have a patient with symptoms on the left and bacteriuria on the right, it's very helpful to make that connection. The problem, I think, is when we forget that both of those things need to be present. There are obviously difficulties with obtaining uncontaminated specimens, particularly in women. I don't do a lot of catheterized urine cultures, but at times, sometimes if we're really struggling to figure out, is this interstitial cystitis or is this recurrent urinary tract infections, sometimes we'll do catheterized specimens in women if you have to know. That's relatively uncommon in my practice. Ultimately, urine cultures are very useful for correlating specific symptoms to bacteriuria. And again, the most common presentation for this is when I see patients referred for bladder pain symptoms, such that they'd be very consistent with bladder pain syndrome. But there's also some question of urinary tract infections, which certainly can hinder that diagnosis. And so it's very helpful to establish that a patient has symptoms today and a negative culture, or symptoms today and more helpful, a positive culture. Then I start to think, hey, we probably need to treat the urinary tract infection and reevaluate before we start treating for bladder pain syndrome. But once the pattern of urinary tract infections are established, routine urine cultures are really unnecessary, right? Because we do have studies to show that in otherwise normal patients, the perception of urinary tract symptoms are as accurate as a urine culture. So when I have patients who have recurrent urinary tract infections that come back and we send their urine for culture, understand what I'm not doing is trying to figure out whether this patient has an infection. She's had 5 infections over the last 2 years. She's pretty confident in what those symptoms feel like to her. So I'm not sending the urine culture to try to figure out whether or not she's infected or not. I'm sending the urine culture because 2 days later, when she's not better on Bactrim, I can refer back to my culture and say, oh, because it was resistant to Bactrim, let's switch her to macrobid. So that's the purpose of urine cultures most of the time in patients with recurrent urinary tract infections. Not some hurdle that they have to jump over in order for you to prescribe an appropriate antibiotic for a symptomatic infection. So how do we actually treat lower urinary tract infections? I know this is not a talk about acute lower urinary tract infection, this is recurrent, but part of the problem of recurrent urinary tract infections is how we treat acute urinary tract infection. So primary treatment should be nitrofurantoin, 100 milligrams twice a day for 5 days, Bactrim, DS twice daily for 3 days, fosfomycin, which I think is dramatically underutilized, but fosfomycin 3 grams in a single dose, though it's probably some inferior efficacy to those first 2. Okay? And I'm reiterating here what the infectious disease doctors will tell you. Be careful, continuing to carry on, I'm allergic to this. As Jay Sizemore said, standing right here, take 3 or 4 or 5 minutes and say, what do you mean you're allergic to this? What does that mean to you? Right? Your mom told you 50 years ago that she was allergic to that or something. There's a lot of times, and I do this all the time in the operating room, right? I'm allergic to every antibiotic. Well, when you start asking questions, all of a sudden you can chip down that list pretty considerably. So ask questions about bacterial about antibiotic allergies. Beta-lactam agents, augmentin, ceftonir, cefaclor, maybe cephalexin. These are all recommended only when these first 3 can't be utilized, either because of resistance or because of a true allergy, but understand that generally there's inferior efficacy of these agents and they have higher rates of adverse events than these first 3. Now, if you have culture results that suggest amoxicillin or ampicillin are appropriate, that's fine, but they should not be used as empiric therapy because the resistant rates are too high. Hugh, what is missing from this list? So fluoroquinolones. So this is not me. This is the FDA. And this has been present for now 2 years. It's amazing to me. Not a week goes by that I don't see a patient treated empirically with a fluoroquinolone for an uncomplicated lower urinary tract infection, not based on a culture, that's not allergic to those agents that any of those agents that I just remarked on. Every single week. Not a week goes by. So the FDA has determined 2 years ago that fluoroquinolone should be reserved for use in patients with no other treatment options for acute bacterial sinusitis, bronchitis, and uncomplicated lower urinary tract infections because the risk of serious side effects generally outweighs the benefits in these patients. For serious bacterial infection, and I would argue that it's tough for a lower urinary tract infection in most people to be a serious bacterial infection, the benefits of quinolones outweigh the risks, and it's appropriate for them to remain as an available therapeutic option. So, why? Well, there's CNS side effects. There's tendon rupture, right? So now it's probably been about 6 or 7, maybe 8 months. I was sitting in the office talking to a lady, and she was telling me about her recurrent urinary tract infections and all these things. And as she's talking, my eyes kind of glance down at the boot that is on her foot. Why does she have a boot on her foot? Well, this is a woman who runs, not professionally marathon, but she runs competitive marathons, or did. And I just in mid-sentence, I kind of interrupted her and I pointed. I said, that didn't happen. She said, yep. So she had an uncomplicated lower urinary tract infection, which the culture results showed was pan-sensitive. She was put on a 7-day course of ciprofloxacin, and the next week ruptured her tendon, her Achilles tendon, and will never run another marathon again. I mean, morally and ethically, that's hard enough to justify in your own mind that you did this to this lady. But legally, you don't have a leg to stand on. Now, just be mindful of this. This is to say, and I still will occasionally write quinolones for lower urinary tract infections, but it's after that list has been exhausted. This really should be the last option for uncomplicated lower urinary tract infections, yet for many people, it's still the first option. So this is where we kind of go off the rails a little bit, and I'm going to hop up on my soapbox a little bit, and this may be where some of you lose me. Are antibiotics really the future of lower urinary tract infections? And this is I'm just kind of posing this as more of a question. So the World Health Organization considers antibiotic resistance one of the top 3 global. We've got all these health problems. And this is one of the top 3 global health problems. Most patients treated with urinary tract infection treated with a placebo are symptom-free within a week. And again, I point out, for hundreds of thousands of years, we as humans got urinary tract infections. We didn't have antibiotics. Somehow we survived as a species. Use of NSAIDs in reduction of antibiotic use. The NSAID arm was found to have symptoms on average for 1 day longer. 2/3 of the women were treated without the use of antibiotics. Though their symptom burden was higher, it was higher by 1 day. We now have 5 randomized controlled trials. 5 randomized controlled trials using either placebo or NSAIDs, or just water or something along those lines, that show no benefit beyond a modestly faster improvement. If you average all the studies out, it's about 1 day of improvement. On average, if you take an antibiotic for lower urinary tract infection, on average, your symptoms will improve in 4 days. If you take NSAIDs or a placebo for your lower urinary tract infection, on average, your symptoms will last, of course, 5 different trials, 5 days. So that's, and I'm not saying that it's not the standard of care, and I'm not saying if a woman walks in as symptomatic urinary tract infection, I don't write a prescription for Bactrim. I do. It's still the standard of care. I just think we need to ask ourselves 5 or 10 or 15 years from now, are we going to look back and say, I can't believe we used to treat an uncomplicated lower urinary tract with antibiotics, and look at all the things that can happen from that. So again, I'm not arguing that this changes the standard of care for today, but it certainly makes me wonder if we're going to be looking at this very differently 10 or 15 years from now. So what should we do for recurrent urinary tract infections? Ultrasound is the primary modality in upper tract imaging, and this is what I use almost all the time. A lot of times I'll add in a KUB just because it's helpful. We get a lot of I'll say overdiagnosis of stones on our ultrasounds around here, and I found the KUB is very helpful because if they say the patient's got an 8 mm stone and I see nothing on KUB, it kind of lowers my likelihood of doing another CT scan or doing a CT scan. But anyway, I usually do an ultrasound and KUB on these patients. I don't do a lot of CT scans unless, obviously, this is a patient in the hospital, you're suspecting urosepsis, and ultrasound I don't think is appropriate. I would do a CT scan, sort of thing. If you got to know, then do the CT scan. If there's a suspicious finding on an ultrasound requiring confirmation, that can be a problem here. We get a lot of ultrasounds with reading of stone that don't have stones. And then if there's any other indication of urolithiasis, right? Recurrent urinary tract infections and right flank pain. In a patient with a history of urolithiasis, I'm probably going to get a non-contrasted CT scan rather than an ultrasound. You know, we'll use some other functional studies. VCUGs can be very important in certain contexts, and MAG3 renal scans can be quite helpful if there's some equivocal finding, like UPJ obstruction or something along those lines. Cystoscopy and recurrent urinary tract infections, I actually utilize this quite a lot and find quite a lot. I'd say almost half of my interesting things that I find, stones in the bladder, mesh in the bladder, God knows what else in the bladder, oftentimes are precipitated by recurrent urinary tract infection evaluations. So it can identify some of the common etiologies for bacterial persistence, right? Certainly if a patient has bacterial persistence, you should be doing a cystoscopy. And we can find stones, foreign bodies, diverticula, tumors. Around here, we find lots of mesh within the bladder and then the urethra. And so that's why I do a lot of cystoscopy. And understand, sometimes people can forget, and sometimes things you don't necessarily remember. You know, someone had hysterectomy 15, 20 years ago, presents for recurrent urinary tract infections. You look in the bladder, and there's a stitch in there. And, oh, you know, you talk to the gynecologist, and she said, oh, you know, 14 years ago, I switched to absorbable suture for my, you know, closing the cul-de-sac. But 15 years ago, I was using a permanent suture. Well, this lady had it done 15 years ago and had the suture in her bladder. So I think this is quite helpful to do. I do it a lot, and every single time I start to think, why am I doing all these cystoscopies in women with recurrent infections just because they had, you know, one pelvic surgery in the last 20 years? Every time I start to doubt it, I see something else in the bladder. Like God's way of reminding me, just keep doing it. You can base selection on risk factors, and I largely do that. You know, if a 22-year-old woman who's has no surgical history, nothing like that going on, I'm much less likely to do a cystoscopy than, you know, a woman who's had 3 C-sections and a hysterectomy. So how can we prevent these recurrent urinary tract infections? First of all, we have to, I said about 10 to 20% will have some kind of anatomic abnormality. You've got to identify that 10 or 20%. Especially if bacterial persistence is demonstrated, I think you should be very aggressive with an anatomic and functional evaluation. So we look for bladder foreign bodies or calculi. We look for urethral diverticulum or bladder diverticulum that empty poorly. I mean, that can be done with something as simply as a cystoscopy and a good vaginal exam. We look for upper urinary tract obstruction, and as I said, I typically use a renal ultrasound and oftentimes a KUB, though in times I think a CT scan is appropriate. We evaluate for bladder outlet obstruction. I always do an independent flow rate and PVR following my cystoscopy. I think it's a pretty good screening test for bladder outlet obstruction, in addition to talking to the patient. Is it difficult for you to urinate? Do you push or strain? Do you lean forward? Anything like that. I'm not saying you do urodynamic evaluation on everybody with a recurrent urinary tract infection. There are some relatively easy ways that we can evaluate bladder outlet obstruction. And then obviously we look for chronic urinary retention. So the vaginal microbiome is dominated by generally lactobacillus species, and these are pivotal in maintaining urogenital health. So we found that replacement of these species by other anaerobic species are associated with a host of symptoms, including urinary tract infection and likely symptoms consistent with overactive bladder. Thomas White found that, and these did sterile suprapubic aspirations, right? So we're not talking about bacterial contamination. And they used DNA analysis, right? So we're not relying on cultures for which lactobacillus, and culture is not particularly great at identifying lactobacillus. So these were suprapubic aspirates that utilized DNA analysis to make sure we knew which bacteria were there. And they found that healthy women, and these are all healthy women, these are not recurrent urinary tract infection patients, anything like that. So healthy women who had a more diverse microflora were more likely to have symptoms associated with overactive bladder and more likely to have a history of urinary tract infection. So when the species within the bladder is predominantly lactobacillus species. Everything is fine. It's when we become more diverse. And here's the analogy I used for my patients and why antibiotics, I think, lead to more urinary tract infections. If I walked out into my front yard and I looked and I saw some weeds in the grass, okay, I have an option. I can go and pull those weeds out. That's fine. An option that I have to kill those weeds is to go to Home Depot and buy the biggest thing of Roundup that I can find and spray the entire yard. And I definitely will kill those weeds in the front yard. But when I come back 3 months, am I going to have more weeds or fewer weeds? I'm going to have a lot more weeds because I've killed all the grass. And what grows back when you kill all the grass is not more grass. It's a more diverse, meaning weeds, than we had before. And I think a lot of times that analogy is pretty apt in the bladder, right? So we have some nefarious bacteria in there mixed among the lactobacillus, and they are causing problems, and it's perfectly legitimate to think that we should try to kill these bacteria. Okay. But when we come and we put a patient on a 10-day course of a broad-spectrum antibiotic like ciprofloxacin and sterilize the urine, don't be surprised when a more diverse microflora grows back and that patient has a higher risk of infection going forward. And that is proven in the data that we'll talk about. So I think that when we see patients with recurrent urinary tract infections, we're always thinking about we need to eliminate the bacteria, and that's the wrong approach, right? Our goal in recurrent urinary tract infections should be restoration of a normal, native vaginal and bladder microbiome. And if you take nothing else away from this talk, I want you to kind of keep that in mind. Eliminating recurrent urinary tract infections is not about eliminating bacteria. It's about shifting the bacteria to a more lactobacillus dominant milieu. Like that word, huh? So how do we do that? Well, probiotics, I think, are important. They may not exactly be the silver bullet we want them to be, but I use them. And, you know, the way I always explain this to either people I'm working with or even my patients, because I spend a lot of time, because one of the things you'll learn is that in treating recurrent urinary tract infections, you're not just treating the patient, but you're treating all of the people that are treating the patient. And if she doesn't understand why you're doing things, what's going to end up happening is she's going to go see somebody else next week, and they're going to undo all of your work. So you have to spend a few minutes explaining to the patients why you're doing it with the hope that when they see one of your colleagues that wants to treat an asymptomatic bacteriuria, you've given them the ability to resist that. So probiotics have some legitimate evidence, but one of the things I explain to my patients is, you know, we always have to weigh the possible benefit versus the possible harm, right? And so the higher the harm is, or the higher the expense is, or the higher the invasiveness of the procedure, the higher that level of evidence needs to be to support it, right? But in probiotics, we're talking about, at least the ones I recommend, a pretty low cost, low side effect, low risk. And so I think the weight of evidence doesn't quite have to be so high, because it's sort of those things where we know we're not going to do any harm, so if we think we're doing some good, it's probably reasonable. And so I still use a lot of probiotics, even though the data are fairly mixed. So studies have focused predominantly on species of lactobacillus, and you can see why. And two strains, L. rhamnosus GR1 and L. reuteri RC14, seem to be the most efficacious. Again, just based on the studies, right? If you didn't study L. rhamnosus GR2, well, it's not going to be efficacious. It's just simply because we didn't study it. So I understand there's a selection bias here. But these particular strains have shown to have some efficacy. L. casei shirota and L. crispidus have also shown promising efficacy, though the data I don't think are as strong. And Lactobacillus GG has shown mixed results in trials of oral therapy. So that's kind of the state of the data. And so we move over here to your right, and that is a list of commonly commercially available probiotics. I did this about a year ago, and so I just went to Target.com maybe, or Amazon.com, and I just typed in probiotics, and I looked for what are the first 5 or 6 things that come up, and then I looked at the data, or the species and subspecies information that was provided by the manufacturer, and that's where this comes from. And so what I found there was, interestingly enough, I was preparing this talk. I read the studies about L-rhamnosus GR1 and L-reuteri RC14, and then the next day I looked at these things online. And interestingly enough, Refresh Pro B is the only one that contains both of these strains that I found. Now, again, this is not a scientific endeavor, right? I just looked at, but when your patients Google probiotic, when you tell your patients, hey, go get a probiotic, you need to know what probiotic are they going to go get. And so I would argue that's probably pretty good. They're going to do the same thing I did. They're going to Google probiotic, and they're going to buy the first thing that comes up that's not too expensive. So I actually will recommend Refresh Pro B to all of our patients. I went from just saying, yeah, you need sort of a probiotic that contains lactobacillus species, to specifically saying you should take Refresh Pro B, which generally comes out to about $16, $17 a month off of Amazon, which is a pretty reasonable price in the world of probiotics. We look at some of the others, Probium, Culturelle, which is actually what I used to recommend was Culturelle, but the data behind the lactobacillus species in Culturelle is not really very good. And so this Hyperbiotics Pro 15, it has L-reuteri, it has L-casei, it has L-rhamnosus. They don't list specific species strains. And so to the extent that that matters, we don't really know. And in fact, Refresh is the only one that lists specific species strains. So that's what I recommend. People want to know, well, I can't just tell my patients they need a probiotic. What probiotic do you recommend? That's the one I recommend, because it's pretty inexpensive. In fact, of these, I think it's the least expensive. It's easily available online, and at least the current data in 2017 would suggest that it's probably the most effective. What about the use of vaginal estrogen? Again, something that we utilize frequently in my practice for patients who demonstrate atrophic vaginitis. So we know that treatment of atrophic vaginitis with vaginal estrogen results in a shift of vaginal flora to lactobacillus dominant species. That's been demonstrated. Treatment of atrophic vaginitis results in a lowering of the pH that more closely matches the pH of premenopausal women, right? So one of the thoughts is that there's a shift, right? Lactobacillus generally prefers a more acidic environment, right? The lacto in lactobacillus obviously stands for lactic acid. It's one of the ways that they inhibit the growth of competing bacteria. So they prefer a more acidic environment. And so one of the things that we see is with the development of vaginal atrophy and atrophic vaginitis, there's a shift of that vaginal pH to a more alkaline environment, which probably is not particularly hospitable to lactobacillus. And so we know that treatment of that atrophic vaginitis can adjust that pH. Vaginal therapy, estrogen therapy, reduces the incidence of urinary tract infection. We know that as well. I think it's important to understand that there's no demonstrated improvement in urinary tract infections with oral estrogen therapy. That should make sense, right? Because at the doses of oral estrogen that are being given today, the effect on the vaginal epithelium is it's marginal. It's just not the doses of estrogen that you deliver when you're using a vaginal estrogen cream. Interestingly enough, what about those patients that you're reluctant to use a topical vaginal estrogen? I'm still not very comfortable in patients with estrogen receptor positive breast cancer, history of breast cancer. Listen, if they're in college, and there's a lot of data to show that that's probably fine, but I'm not going to do it. I'm not an oncologist. I'm not comfortable making that recommendation. So what do I do in those patients? Well, Refresh makes a vaginal pH adjuster, right? A wash that can adjust the vaginal pH. And I don't know of any data that supports that, but I think it's a reasonable thing to do. Again, right, low harm standard of evidence probably lowers as well. So for those patients that I'm uncomfortable, I certainly refer them back to whoever's managing their breast cancer, and they can have that discussion, and sometimes they allow them to go on a small amount of topical vaginal estrogen. But for those patients that don't, we can use a pH adjusting wash. So something that is, and I think I misspelled mannose here. I think it's M-A-N-N-O-S-E. So D-mannose in recurrent urinary tract infections, and I've been hearing about D-mannose for years now, but I've been hearing about everything: toadstool and dung beetle antenna and all kinds of stuff for recurrent urinary tract infections. And so I generally ignore most of these things as sort of background noise, but I don't think we can ignore D-mannose anymore. So how does it work? So D-mannose is taken orally and is secreted into the urine. It binds and blocks the FemH adhesin, which is what the fimbria of enteric bacteria use to adhere to the bladder wall, to the urothelium. It acts as a competitive inhibitor to bacterial persistence, right? So the idea is that it can bind to these fimbria and reduces their likelihood of binding to the urothelium. You don't bind to the urothelium, you have a difficult time infecting the urothelium. So, and this is what changed my mind. So a randomized trial of over 300 patients found that D-mannose, 2 grams a day, I gave a gram in the morning, a gram in the evening, 2 grams of D-mannose a day, reduced the recurrence in patients with recurrent urinary tract infections similarly to nitrofurantoin prophylaxis, which is what I had generally been using prior to that. So 300 people, recurrent urinary tract infections, break them into 3 groups. 1/3 we do nothing. 60% of those patients get a recurrent infection. 1/3 we put on nitrofurantoin prophylaxis. 20% of those patients get and again, that's kind of what we would expect. It's a 66% reduction. That's generally what I saw in my practice using trimethoprim and nitrofurantoin prophylaxis. D-mannose for 90 days. I'm sorry, for 6 months. 15% reduction. 15% got a recurrent urinary tract infection, a 75% reduction. Statistically significant to the nitrofurantoin prophylaxis that I was prescribing. Side effects, as you can imagine, were considerably decreased compared with the antibiotic prophylaxis. So just as successful without any of the side effects or the potential harm. And again, if the idea is that we're trying to benefit the normal native microflora, if we can avoid the use of a prophylactic antibiotic, there may be something to that. And I will tell you, since I came upon this, it was about a year ago, most of my patients who normally I would have prescribed a low-dose prophylaxis for 90 days, I use D-mannose. And I think I see fairly similar results to what I did when we were using trimethoprim and prophylaxis. Not an elimination of recurrent urinary tract infections, but probably somewhere between a 2/3 and a 3/4 reduction. What about antibiotic prophylaxis? I think there's still some role for that. So long-term use of antibiotic prophylaxis does not reduce overall infection rates. So at a year, patients on low-dose prophylaxis have the same rate of urinary tract infections as patients not on prophylaxis. So do not put a patient on low-dose prophylaxis and say, I'll see you back in a year. Don't do it. You're not doing anything for them. But prophylaxis is associated, you just saw, with a short-term reduction in the frequency of infection. And that can be helpful because if you use trimethoprim, nitrofurantoin, or even cephalexin, but certainly I typically will use nitrofurantoin or trimethoprim, they have a minimal long-term effects on native gut and vaginal flora, especially at these low doses. Nitrofurantoin I use 50 milligrams nightly, trimethoprim 100 milligrams, okay? So they have some effect, but it's minimal. So if I can reduce by 66 to 70% a patient's likelihood of getting an infection over that 90 days, what I'm really doing is at the small trade of some effect on their native flora, what I'm really getting is not using Cipro, not using Augmentin, not using those things. And so going back to that lawn analogy, what I tell my patients, it's, well, we're using some Roundup, but we're just spraying the weeds. We're not spraying the entire grass. Again, I use this much less now that we find D-mannose. And so I'll use this in patients who have breakthrough infections on D-mannose, which should be 15%, right? Or I'll use this on patients with that I just, for whatever reason, I can't afford to have them have another infection, right? They've had 3 urinary tract infections in the last year, and they all resulted in hospitalizations with urosepsis. That's probably a patient that I think warrants a low-dose antibiotic prophylaxis plus the D-mannose. But for my, yes, ma'am. Yeah, and I tell them, we have a handout, I have them print out a little, the first one that comes up is called Now is the brand name. D-mannose is a little different than antibiotics, so we'll talk about, than cranberry extract, because cranberry extract, there's no denotation there on the PACs, and we'll talk about why that's so, the proanthocyanins. On D-mannose, it's, unless they're lying, they could lie and say, we've got 1,000 milligrams of D-mannose in here, and they could just lie, and that's fine. But it's on the package, so I don't think the packaging, the brand matters. So I just have them go on Amazon, and it's about $16 or $17 a month. I do use postcoital prophylaxis, though, in those patients who regularly associate infections with intercourse. And I think for those patients that every single time they have an infection, it comes after intercourse, I think postcoital prophylaxis is really quite useful, and I'll still use it in that instance. So what about cranberries? And so listen, those of us who were have had our ears open for the last 20 years, understand about cranberries and recurrent urinary tract infections. You may or may not know it's the proanthocyanins, the PACs, that are found in cranberries that are thought to keep E. coli from binding bladder cells. Kind of the same, similar, I should say, to what we see with D-mannose. The studies on pure juice are mixed, right? Some data show some improvement, some data don't. Again, low bar for efficacy when your risk factors with cranberry juice are probably pretty low. Here's the two problems with it. Number one, cranberry juice, 100% cranberry juice for most people is intolerable. They just don't drink it. And when you start to look at cocktails and juice cocktails, the amount of cranberry juice you'd have to drink, right? If it's 20% cranberry juice, you have to drink 5 times what they saw. That's like 40 ounces of cranberry juice cocktail a day, which is a ton of sugar and expensive on top of that. So cranberry juice treatment is really very poorly tolerated. And this is something, somebody might stay on this for the rest of their lives, at least for 6 months. So, that's a difficult sell. So we look at cranberry extracts. And here's the problem with cranberry extracts. A nice study that was done a few years ago looked at 7 different cranberry extracts, and they actually figured out a way to figure out what is the concentration of proanthocyanins across these extracts. Is it the same? Because, they all say we have proanthocyanins, but how much? They found a 30-fold difference among 7 different commercially available cranberry extracts. A 30-fold difference. So I always tell my patients, it's like saying, all right, I'm going to write you a prescription for ciprofloxacin. I'm not sure. It's either the 500 milligrams or the 15,000 milligrams. I'm not really sure which is it going to be. But just take it and we'll see what happens. So that's the problem, is we don't know. When maybe PACs are very effective, maybe that's what we need, or maybe it's something else in the juice altogether. But the problem is, who knows how much PAC that you're getting? They even found among some brands a 12-fold difference within the same brand. So even if you found the right brand, the one with the 30, not the 1/30th, there can be as much as a 10-fold difference in between there. So that's why I generally don't recommend cranberry juice extracts, because you don't really know what you're getting. And finally, glycosaminoglycan layer replacement in recurrent urinary tract infection. So we have the umbrella cells of the urothelium. They're covered by this hydrophilic charged disaccharide layer we call the glycosaminoglycan layer. It includes components of hyaluronic acid, heparin sulfate, chondroitin sulfate. We all know a lot about this from the interstitial cystitis data, right? We've been talking about the gag layer forever in treatment of bladder pain syndrome. But it's thought that this also creates a antimicrobial barrier for the bladder, and one study showed attenuation of gag layer increased bacterial adhesion by a factor of 100. So that sort of spurred people to think, hey, we use this all, and I use this all the time in treatment of patients with bladder pain syndrome. How important could the gag layer be in infections? So there are studies that show patients can benefit in terms of recurrent urinary tract infections with installations of hyaluronic acid, heparin, and chondroitin sulfate administered intravesically. Now, the problem is this is an off-label use. Both hyaluronic acid and chondroitin sulfate are quite expensive. And so this is something patients are generally paying for out of pocket. And so I don't typically use chondroitin sulfate or hyaluronic acid because it's hundreds of dollars for these installations. Heparin is cheap. Heparin is very cheap. And so what I'll typically, and there are studies to show a significant reduction in recurrent urinary tract infections with heparin. One study that looked at patients administered for 6 weeks, once a week, and there was a considerable reduction in recurrent urinary tract infections. And so in patients, this is not my first thing that I do when patients walk in the door, but we will typically use intravesical installations of heparin, and we'll buffer it and put some Arcane in there because it can be uncomfortable in some bladders. And I think in that study they showed almost a 70% reduction. I'm typically using this in my patients that have failed a lot of other things, and we probably see about a 50% reduction in a 50% success rate, I should say, in those patients not having recurrent urinary tract infections. I don't think it's quite as good as the patients I've seen in the studies, but again, I'm probably using it more in those really difficult to treat patients, so that may be one of the reasons. But it's certainly something you can do and something we do. So last 10 minutes, the second thing that I want you to come out of this is let's talk about bacteriuria, what it is and what it isn't. So, 10 to the 5th CFUs, right? That's a significant, 100,000, right? That's a significant culture. Anything less than that, it's not significant. Maybe if it's a cultured catheterized specimen, all those kinds of things, right? So where does that come from? And I don't know that I'd ever seen this, heard this, thought of this at all until preparing this talk. So that number comes from a 1956 paper. I'll read the paper. It's, one of those old, looks like it's on microfiche or something like that. But you read the paper. I did. And they quote them. I quote them in saying 10 to the 5th colony counts is chosen, quote, arbitrarily as the dividing line. So this is just a number they pulled out of there, an educated guess. And they were trying to distinguish between bacteriuria and contamination. And they thought that sounded like a pretty good number. It's sort of like glomerulations in 3 out of 4 quadrants as a diagnosis of interstitial cystitis. It sounds reasonable. To date, no specific colony count has been demonstrated that predicts those likely to become ill or likely to show benefit from antibiotic treatment. So we don't know what a significant number, if it's 100,000, 50,000, 25,000, because no specific colony count has ever been determined to say, hey, with this patient's likely to get sicker. You need to treat this. Or these patients, if you treat them with antibiotics, they improve, whether it's 100 or 50 or 25. So that number that my nurse is saying, nope, it's 75,000 CFUs, or it's 50,000 CFUs, or it's 25,000 CFUs. You can't possibly have a urinary tract infection. That number she's relying on is an arbitrary number that was picked 60 years ago. That's it. So, second factor about bacteriuria is bacteriuria and infection are not the same things at all. So so this is an older paper, but I think it's still relevant. Looked at older men and women who were bacteriuric and non-bacteriuric during the survey. So they basically kept checking urines over the course of a year. These are older patients, right? So we know 30 to 50% of older women, are going to be bacteriuric at some point. So let's follow them longitudinally. And they found that presence or absence of bacteria was not associated with frequency, urgency, suprapubic pain, malaise, weakness, or fatigue. Right? They're just as likely to experience all these symptoms with or without bacteriuria. Dysuria was excluded, and I think that's important, because dysuria is the single most reliable factor for an indication of urinary tract infection. And so it was excluded from that study. So it brings us to the point about asymptomatic bacteriuria. So urinary tract symptoms, so it's an interesting point. I think this in some ways almost argues against my point, or it doesn't support it necessarily. But I think it's important to point out because people always worry, what happens if we don't treat asymptomatic bacteriuria? But identifying infections ahead of time in older patients is not particularly useful. I think that's the point of including this. So they actually looked at older patients, older than age 75, who were admitted to the hospital for urosepsis or pyelonephritis, and they had bacteremia, right? So they had urine cultures that were similar to their blood cultures. In these 37 patients, only 1 out of the 37 actually reported having dysuria ahead of time. So on the one hand, I think that, but that's not, they may not have even had bacteriuria, we don't know ahead of time. So, symptoms are helpful, but they're not the most reliable thing either. But let's move on. What about asymptomatic bacteriuria and pyuria? Well, certainly that should be treated, right? I've got white blood cells. Well, pyuria appears commonly in older patients with bacteriuria. And there is no evidence that the presence of pyuria in these patients predicts any benefit from antibiotic therapy. So the IDSA guidelines from 2005, right? This is not cutting edge. The IDSA guidelines, which have not changed from 2005, says that pyuria accompanying bacteriuria is not an indication for antimicrobial treatment in an otherwise asymptomatic patient. So an asymptomatic patient who has a culture that's positive and white blood cells, but is otherwise asymptomatic, needs to remain untreated. There's strong evidence against any benefit from treatment of asymptomatic bacteriuria for elderly men, elderly women, whether they're institutionalized or at home, catheterized patients certainly, premenopausal women, and women with diabetes. All these populations some of these populations that we think, oh, well, I need to treat old people with asymptomatic bacteriuria. No, you do not. Well, I need to treat patients with diabetes, right? No, you do not. I hope we're not treating catheterized patients with asymptomatic bacteriuria. That's another talk, but let's not do that. Who does need to be treated? Well, pregnant women, obviously, because of the risk associated with pyelonephritis and preterm labor. So everyone would still argue pregnant women. And of course, those undergoing urinary tract procedures likely disrupt the mucosa, right? So every single time I do Botox, if a patient has a positive culture, even if they are asymptomatic, I treat them because I'm going to disrupt the mucosa 20 to 30 times. And so they're going to be treated. There's no evidence to show that treatment of asymptomatic bacteriuria results in improved outcomes for delirium, falls, or confusion, right? What's the most common thing I see for recurrent urinary tract infections is someone who's old and they get confused a lot. And I ask, well, but they get confused a lot otherwise, right? Yeah, but when they get really confused, we treat them for a urinary tract infection. So the IDSA guidelines, again, for non-catheterized residents of long-term facilities, delirium is not a reason to send a laboratory test for urinary tract infection, because 30 to 50% of the time that culture is going to be positive because they have bacteriuria. But there's no evidence to show that treating that asymptomatic bacteriuria improves the delirium, improves the falls, improves the confusion. Yet, in 2005, they found the most common reasons cited for suspecting urinary tract infections in a long-term care facility were, number 1, altered mental status. Number 2, change in behavior. Number 3, change in the character of the urine. Of those, the only appropriate indication named here, which would be dysuria, was only the indication for suspecting urinary tract infection in 8% of patients. And again, why is that so important? Well, because the range of bacteriuria in nursing home residents ranges from 15 to 50%. So if a long-term care facility patient is confused and you send their urine off for culture, there may be a 1 in 2 chance it's going to be positive, even though treatment of the bacteria has no demonstrable effect on that confusion statistically. So who cares? What's the harm? So great-grandma's a little confused. Give her some Bactrim. It'll make everybody feel better. Your patient comes in, you just write the antibiotic. It's easy. It gets them out of the office. And I would be fine with that. Listen, if there's no harm from antibiotics, put it in the water. I don't care. But there is harm. And that harm comes from destruction of the native microbiome. And I think that's why I see so many recurrent urinary tract infections. Because we give so many antibiotics and for such long term, and we use it so indiscriminately, that I think it provokes the very thing that we're trying to treat. So in a randomized trial of 673 women, at mean age of 39, they were randomized to treatment or observation of asymptomatic bacteriuria. The treated women were more likely to have a symptomatic urinary tract infection a year. So we're treating asymptomatic bacteriuria, and we are precipitating a symptomatic urinary tract infection, right? What does first do no harm mean? First, don't do any harm. And I think we are doing harm. At 27 months, treated women were more likely to have a recurrent urinary tract infection, to have a poor quality of life, and pyelonephritis was more common. Clear evidence demonstrates that urine is not normally sterile and that antibiotic use disrupts the normal microflora. And so this is one of the things, and I realized when I was putting this together last night that I still haven't gotten this back from the printer, but I put this together. And so this is basically something I did is facts about urinary tract infections. And the idea is I can hand this to my recurrent UTI patients. And some of it's for them, but honestly, some of it is for the people they're interacting with in the healthcare system. I almost wish I could make it wallet size so they could carry it around with them. But I think you have to empower your patients. It's not just enough for you to know how to do the right thing, but you have to educate your patients on how to do the right thing because they have to protect themselves because you can't go around with them to every office visit they go to. You know, and when they go to have a health physical for work and someone looks at their urine and says it's, you know, leukocyte esterase positive and writes a 7-day course of ciprofloxacin, you've got to be able to empower them to be able to do those things. And so this is one of the things I put together, and I think it'll be helpful. The bottom half is about catheter infections, and again, that's a whole nother talk. So we're running out of time here, but how do I approach recurrent urinary tract infections? I think to put all this together, number one, we make sure that the symptoms are really related to urinary tract infections, right? What's the most common diagnosis? Let me put it this way. What's the most common misdiagnosis of bladder pain syndrome? It's urinary tract infections, right? I think the average bladder pain syndrome patient has been treated for 2 or 3 urinary tract infections before they receive a diagnosis of bladder pain syndrome. So you have to make sure that the symptoms are actually related to infection. And listen, as much as I badmouth cultures, that's probably a really good use for cultures. Symptoms correlate with infections. Then we need to evaluate, just another little tidbit, especially for the younger guys. I have recurrent urinary tract infections. Okay, tell me what symptoms you have when you have well, it burns when I urinate. That sounds like a lot like a urinary tract infection. What happens? Well, I take an antibiotic, and what happens when you take an antibiotic? Well, the symptoms get better 3 days later. That's probably a recurrent urinary tract infection. Easy question to ask. Does that happen again and again and again? Well, that's a pretty good establishment of recurrent urinary tract infections. So what happens with therapy? We need to evaluate for any underlying functional or anatomic abnormalities. We need to manage acute lower urinary tract infections with good stewardship, right? I think the chief cause of recurrent urinary tract infections are iatrogenic causes. And so we need to not be those iatrogenic causes. But I'll typically use, and here, I sometimes wonder, I do all this probiotics and D-mannose and vaginal atrophy, and I think we're really successful with managing recurrent urinary tract infections. And I sometimes wonder if it's not just because I don't write 7 days of ciprofloxacin or 10 days of ciprofloxacin for an uncomplicated urinary tract infection in a woman. I wonder if some of our success is not all this other stuff, it's just this first one. It's just appropriate antibiotic stewardship. That there may be a reasonable study in there somewhere. But I use daily probiotics. I use treatment vaginal atrophy when it's present. I use a lot of D-mannose, a lessening amount of low-dose prophylaxis. I usually use a 90-day prophylaxis, so if the infections are not more frequent than 90 days of prophylaxis is not going to do very much for you. So they have to be pretty frequent infections. I will sometimes use methenamine and vitamin C, kind of an older way of doing things, but I think in some patients can still be effective. It's not terribly well tolerated, so it's not sort of a first-line therapy for me. And in some patients, we'll even use glycosaminoglycan replacement. So, appropriate treatment of recurrent urinary tract infections, I think, starts out with appropriate treatment of acute lower urinary tract infection. We have to diagnose it appropriately, find those 10 or 20% of patients that have an underlying anatomic abnormality. And for the rest, there are multiple strategies that exist for recurrent UTIs. And again, they mostly focus on restoring the normal vaginal and urinary microbiome. And I think inappropriate treatment of asymptomatic bacteria provides no substantial benefit and probably results in significant harm in the development of recurrent urinary tract infections. That's it. Thank you.
I think that 10 to 20% anatomic abnormalities, that number has to be higher in men. So I have a higher index of